Good afternoon, everybody. At the outset, I would like to thank Dr. Muralidhar to have given me a chance to speak on this topic. Hopefully, next year we can meet offline and not online. Let me start with my topic, interesting TE cases in ICU. We know that TE is a very powerful imaging tool in the ICU because it's immediately available. It prevents any delay in diagnosis in the ICU. It can be used in any intensive station. We are using it in cardiac surgical, pediatric cardiac, even pediatric non-cardiac surgery, and general ICUs, cardiac ICUs. So any compact interdisciplinary intensive station, we can use a TE. But the most important thing for a TE is it requires a dedicated training. So TE is performed mostly by people who have an advanced level training. Either they are cardiac anesthetists or European intensivists with advanced echocardiography or American intensivists, but they all have to have advanced level training. The indication for doing a TE in the ICU is mostly acute and hemodynamic instability. It can be any cause like a pericardial effusion or a pulmonary embolism, regional wall motion abnormality, etc. So once we talk about dissection, dissection can be either because of a penetrating ulcer in the thoracic aorta. Dissection can be in the descending, ascending aorta, arch of aorta. Mostly we see pericardial effusions, which can be mild PE, which is less than 10 millimeters, to massive PE, which is more than 25 millimeters. And they look something like this, a mild one, reaching to a severe, where you see that the RV is getting compromised. Other than that, you have pulmonary artery embolism, a very acutely unstable patient. You may have a thrombus in the MPA or the right or the left PA. Patient will have signs of acute pulmonary embolism, which is a dilated RV, as you see in this picture, an empty LV, septum puts towards the left, and of course, a tricuspid regurgitation. We also have ARDS. ARDS is in the intensive station. Why do we need a TE? To rule out right to left shunts. Now, in ARDS, since Berlin criteria came in, the use of PA catheters to measure the wedge pressures has gone out. So patients usually qualify as having an ARDS when they have respiratory failure, which is not explained fully by a cardiac failure or a fluid overload. And if no ARDS risk factor is apparent, then you need an objective evaluation to eliminate the cause of hydrostatic edema. And this is seen with a TE, any echocardiography, but it is better that in the ICU, we use a transesophageal echo. Other than that, if an urgent indication can be a valvular abnormality, either it can be a native valve or it can be a prosthetic valve. Other than that, a pump can be dysfunction after myocardial infarction or ischemia. What about trauma? We have trauma cases in ICU. Do we really need to use a TEE? Of course, it depends on the indications. If it's a polytrauma, you are scared of an esophageal damage. So should I always do a transesophageal first and then do a TE? If I put a TE probe, should I leave it inside? If there is a competent echocardiographer to do a TTE, should I use that? And are there any relative and absolute contraindications? These are the questions which come to our mind. But there are few goal-directed TE views which can be used in a trauma patient, which are mid-esophageal four-chamber view, mid-esophageal bicaval view, transgastric mid-papillary view, and evaluation of the pleural spaces. Let's go to some case scenarios. This is the first case scenario where there is a 68-year-old man who is morbidly obese, has a history of obstructive sleep apnea using home BiPAP. He gets a sudden onset of severe dyspnea, goes into a florid edema, is admitted in a tertiary hospital. His transthoracic is done, his CT is done. He goes on to a very high supports of noradrenaline, and he's on a FiO2 of 100% with a high PEEP and still having a PO2 of 120. The X-ray shows a left whiteout. Echo is done, and the echo shows on the mitral valve an unclear structure which you're not able to see what exactly it is. So a transesophageal echo is done. And here we see that there's a flail. And because of the flail, there was a coneda effect. The jet was going more towards the left side. The valve is replaced. And what we see is postoperatively, the noradrenaline dosage comes down, the person ABG improves, and he's extubated. So this is one case where when we see a unilateral pulmonary edema, we cannot even think that the patient may be having something in the mitral valve. And this is the case, as you see on the left side, the X-ray before the surgery, and the right side, the X-ray after the surgery. The next case is a person who had a motor vehicle accident, comes to the ICU with a shock state and is ventilated. Transthoracic pictures are very difficult. And then transesophageal is done, which shows that the patient has a cardiac tamponade. So pericardiocentesis is done, and we see that the size of the ventricles are gradually increasing as the pericardial fluid is removed, which suggests that the high intrapericardial pressures prevented a normal diastolic filling. You can see in this video very clearly. The next case scenario is an 82-year-old man with diabetes, ischemic heart disease, COPD, goes to have a arthroplasty, and after an hour, after the surgery, comes to the ICU, he becomes hypotensive, the EtCO2 is low, he's desaturated, TE is done. And we see here that the septum is pushed to the left side, the RV is dilated, and when you see this view, mediasophageal ascending aortic short axis view, we very clearly see that in a PA there is thrombus. The next case is another 64-year-old ischemic heart disease patient who's admitted to the ICU with congestive cardiac failure. He develops fast atrial fibrillation, and we think of converting the patient, want to cardiovert the patient and do a TEE. And what do we see in the TEE is there is a left atrial appendage thrombus. The next case is another 70-year-old with severe calcific aortic stenosis, scheduled for an aortic valve replacement, goes to have an uneventful surgery, shifted to the ICU. 1 hour after this shifting back to the ICU, you find gross ST segment changes, goes back to the CPB, and they think that they have to revascularize the LAD. A routine TE is done. This is the valve. There's no AR or something like that. But in the mid-esophageal aortic valve short axis view, there's one structure which is floating in the left main. And that happens to be a calcific plaque. And on CPB, this aorta is open, and the calcium deposit, which was seen to be obstructing the left main, is removed. ECG normalizes, and patient comes after CPB with an uneventful post-op. This is another case where a 51-year-old gentleman is admitted to the ICU with chest pain radiating to the back. ECG, transthoracic echo normal, transesophageal echo done, and it shows an intramural hematoma. This is another case where a 67-year-old has undergone a mitral valve replacement 5 years ago. She had a complicated clinical course with persistent heart failure, atrial fibrillation, severe pulmonary hypertension, neurological symptoms. TE done here. And as you see, that there is a thrombus floating on the mitral valve. In fact, there's a pannus formation on the mitral valve. This is a very interesting case. 56-year-old female post-CABG. After surgery, she comes to the ICU with a very normal ejection fraction with no inotropes. Just a mild MR was seen in the OR, and the surgeon said no intervention required. She comes to the ICU, and there's a slight drop in pressure. Considering mild MR, the ICU resident starts dobutamine. Patient goes into severe hypotension, not responding even to high doses of norepinephrine. Here the echo is done, and it's seen that there is a SAM. The septum is almost 1.5 centimeters thick. So it's a sigmoid septum. So in the theater, this was seen, but nothing was done because there was not much MR. But when the patient comes to the ICU, this is the level of MR which is seen. A Morrow resection is done, and post-Morrow, this is the absolutely no MR. Again, a very interesting case, 55-year-old male, CABG done, very low ejection fraction, 30%, uneventful till the third postoperative day. On the fourth postoperative day, the patient develops left-sided weakness and the CT shows a parietotemporal infarct. TEE done, and what do we see? In the TEE, we see there is an LV thrombus, and it is not an artifact, it is an LV clot. Surgeon refused to do a surgery, and the patient was put on a high dose of heparin and warfarin. And hopefully the patient doesn't come back again with some other. So thanking everybody for a patient listening.